Good morning. Welcome. Thank you, everybody, for coming to Primary Children's Pediatric Grand Rounds, and everybody online and at the Lehigh location as well. And I'm Miguel Canockle, one of your pediatric hospitalists and the course director. Today's Cloud CME claim credit code is 52531. That's 52531 for everybody to claim. The online questions go in live chat, not comments, but live chat. And for those in the auditorium, just raise your hand and we unmute the overhead microphones for questions at the end. Okay, you can register for topics in children's health. This is Dr. Giardino's two-morning conference on those 2 mornings held at Eccles in Salt Lake and also broadcast to like 5 other places for in-person with breakfast. It's going to be amazing across the 5-state area, or you can join virtually from home and make your own breakfast. There will be 10 specialists teaching here, and each of them will have like a top 3 really practical thing for pediatricians. So we're holding this while the Common Problems Conference that we've had before is on pause this year, while the Utah AAP focuses on the advocacy. Will you please nominate a safety hero when you see someone use error prevention technique to prevent harm? So today for Safety Moment, I'd just like to encourage everybody to go look at your disaster flip charts, because today is Great Utah Shakeout, kind of earthquake day. So to prepare for earthquakes, or go update your 3-day kit if you're feeling really ambitious. Okay. I should see if my 3-day kit still has baby diapers in it. I don't know. Okay. Okay, and now Dr. Tiffany Glasgow, Chief of Pediatric Hospital Medicine, will introduce our speaker.
He's got big print. I need that. It is such a delight to welcome Dr. Susan Sample here to Pediatrics. There's people beaming in the room for those of you who are online. Dr. Sample has been an inspiration, personal inspiration to me and my family. My daughter pursued a master's degree in narrative medicine after working with Susan prior to starting medical school, and is busy in med school right now, but really wants to lean into that more in the future, as do I. Her work, for those of you not familiar with the field of narrative medicine, it really heals by allowing patients and caregivers this space and medium to tell their stories, and probably more importantly, to be heard. Rita Sharon, who's one of the founders of narrative medicine, describes it as radical listening. And I think that you can't underestimate the importance of that in our lives as caregivers and healers. And I do want to read Dr. Sample's bio because it's so impressive. She is an associate professor emerita. Thankfully, she's still around and sharing her brilliance with us, of internal medicine at School of Medicine. She founded and directed the Initiative in Narrative Medicine and Writing at the Center for Health Ethics, Arts, and Humanities at the University of Utah. She continues as the writer in residence at the Huntsman Cancer Institute, where Dr. Sample guides patients, caregivers, physicians, and staff in reflecting upon and writing about their experiences. She received her BA in philosophy from Whitman College, an MFA in creative writing from the University of Arizona, and she completed her PhD in communication, focusing on rhetoric, narrative, and medicine from the University of Utah. Her research explores the rhetorical ways physicians and patients use narrative, particularly related to the end of life. She taught medical humanities and reflective writing in the School of Medicine. She also was a faculty advisor for the Literature and Health discussion group, healthcare discussion group, and medical students literary journal Rubor, Reflections on Medicine from the Wasatch Front. She continues to facilitate the resident physician writing group. I know Bridge is in there. Dr. Sample is the author of a full-length poetry collection, Trapped in the Bone House, which is spectacular. And it was selected for a finalist for the 2025 Utah Book Award in Poetry, and 2 poetry chapbooks, Terrible Grace and Some Unsayable Blue. In spring of 2021, she published Voices of Teenage Transplant Survivors, Miracle Like, which describes poetry workshops she led for 12 years for adolescents who had heart, liver, and kidney transplants. Her poetry has appeared in multiple journals, ranging from literary journals, including Tupelo Quarterly, to medical journals, including JAMA and many others. I'd like to welcome Dr. Sample.
Thank you for such a warm introduction, and I appreciate it. And it's wonderful to see some familiar faces in the audience here, and I'm sure familiar names online. So I appreciate that. We'll go through the required slides. Don't need a lot of explanation there. So I wanted to start that narrative has a rich history in medicine and health, much longer than people realize. So I wanted to start with just a brief summary of some of this. So Catherine Montgomery Hunter, who's the author of the book at the bottom, Doctor Stories, was an English professor at the Morehouse Medical School when she was recruited by the University of Rochester in 1983 to explore how the theory and methods that are used in the humanities, how those might be then applied to medicine. She had a grant from the National Science Foundation. So for 2 years, she conducted research at Rochester and 3 other hospitals to look at this. And she found that narrative has long been used in medicine to structure and convey medical knowledge, which is probably not surprising to us, but in 1983, that really was somewhat revolutionary. And so these have become historically sanctioned uses. One, of course, is recognizable, the patient histories. Those are essentially stories. And they're case histories that are taken. The information that the patient provides is then recorded, objectified, and then that helps advance medical knowledge. And then it's also used in kind of the reverse way, in a kind of deductive way, where that general information is used for individual patients. Also, and this was something that hadn't been recognized quite as much either, that patients' bodies are actually read. Clinical knowledge is filtered through the physician's consciousness and body, and that makes the patient more knowable. And so I do have the words both taken and read in italics or quotation marks. And I wanted to draw attention to those. Those are both written in the passive voice, which is what you're used to when you're reading about scientific knowledge. But both of those words also point out the power relationship between the physician and the patient, which is particularly meaningful from a rhetorical standpoint. The physician takes the patient's history and reads the body. Both of those actions are mediated by the physician's subjectivity. So although medical knowledge is scientific, and there are some that we would say is objective knowledge, there's a subjective aspect here. And again, that was somewhat revolutionary. Tricia Greenhalgh and Brian Horowitz built on some of this work. They're 2 British physicians. Their book is a compilation of essays from physicians in the US as well in the UK. And what I found very useful is that they started looking at interpretive tools that are used in diagnosis in clinical practice and saying how we can also look at these as narrative. So one, we talked about what the patient says, the patient history. That was referred to as the experiential text. Then you have the narrative text, and this is where the physician will take it, and it becomes a problem is identified. So that's a different text than the patient history. The physical text, as I said, that the physician reads the patient's body, and so that we have the physical text here. The instrumental text, and I think this is especially important because I think we often don't think about things like blood tests, x-rays, diagnostic tests as narratives, but they are. And I'll later talk about a definition of narrative and refer back to this. and the therapeutic narrative. This is the treatment plan. So it's important to note that each of these types of narratives requires interpretation, further supporting Montgomery Hunter's finding that the structure of medical knowledge can be subjective. The authors, though, I want to point out, do not discount medicine's objective knowledge base. In fact, the final essay in the book by Tricia Greenhall is a very good one entitled Narrative-Based Medicine in an Evidence-Based World. So saying it's neither one or the other, but how those can be used together. Arthur Kleinman was a very early advocate calling for physicians to incorporate medicine into medical practice. He is a psychiatrist and a medical anthropologist at Harvard. And for much of his career, he traveled and researched the cultural context of medical practice. And he said, listening to patients' narrative is a core task in the work of doctoring that is atrophied in biomedical training. Yet is extremely important, the listening in the narrative, because it improves the doctor-patient relationship and it can result in more appropriate and effective patient care. He actually emphasized very early on, so that this was, again, in the 80s, the importance of recognizing patients as a body, mind, self. And he said by using narrative, physicians could help patients restore a sense of this wholeness. So many of you are familiar with Dr. Rita Sharon and her seminal book. I think it's a classic, Narrative Medicine, Honoring the Stories of Illness. I have narrative medicine in quotation marks here because this is a way that Dr. Sharon is the one who really has, I want to say, in a sense, popularized and really be able to put into practice the use of narrative in medicine. She's probably one of the most, if not the most, recognizable expert today. Many people attribute the field of narrative in medicine to her, although, as I've discussed, there is a long history before that, which she draws on and does talk about in her book as well. Dr. Sharon's an internist at Columbia University. And she'd always been fascinated by the stories that patients told her. So she told me how during a fellowship year, she decided she wanted to take a class in English literature. That was something she'd never really studied much. And so she took a class. She eventually ended up earning a PhD in English literature and saw that the overlap and the benefit and the advantages that narrative can bring to medicine prompted her to create narrative medicine and then to actually develop courses and what has become a well-known program in narrative medicine at Columbia. I know some of you have probably taken courses, received certification, if not a master's degree in this academic field, training with Dr. Sharon, or perhaps with some of her graduates who've initiated programs at their respective institutions. Foundational to narrative medicine, according to Dr. Sharon, is her call for physicians to become, and I should say not just physicians, for clinicians, because she puts in here physicians, nurses, any other healthcare professionals who are dealing in direct patient care. And she calls for them to become clinically, not only clinically competent, but narratively competent, thus the competence there. And she feels that this will provide the best patient care as well as improve the quality of clinicians' professional and personal lives. And so that's something we're talking about here. One of the benefits is the deeper empathetic engagement with patients. And this is through becoming more attentive, really listening to experiences. And through some of this, that she feels that clinicians can more accurately interpret the stories patients tell them, as well as narrative helps them develop a clinical imagination. It's also, she says, an opportunity for self-reflection and self-knowledge. That by listening to the stories of others very empathetically too, you began to examine what does being a clinician mean to you professionally, and that to understand that the most therapeutic instrument is often the self. And when I've taught medical students, that was one of her statements that has always drawn, I want to say, attention. And medical students often feel actually very encouraged by that too, because I think this is one area of medicine where you can pay attention to that and realize that yourself is very important in the care. And it also, narrative medicine, can bring awareness to the ethical dimensions of clinical practice. That as you increase your awareness, your empathy for pain and suffering, you are open then to perhaps being aware of more social injustice and perhaps doing something to help alleviate some of that. So what I want here to do is to introduce you to the 3 foundational tools or techniques for narrative medicine. First is close reading. And this actually stems from Dr. Sharon's background research in literature. And this is where you listen to what the patient is telling you as a story. So you want to listen for, where does this story take place in time and space? What about the voice? You can get a tenor of a voice as you're listening, or if you're reading something, sometimes you can figure out what does that voice say. But also voice in the terms of, like I was talking before about passive verbs, that something's taken, that something's read. That's where the speaker doesn't have a lot of agency, and that's important. I was working with a patient once, and it occurred to me that she kept talking about herself through the passive voice, which made her a victim, and kept not forcing her, but encouraging to stay in that role. So it was like, well, what if you write it in a different way? And so you're the one taking the action. You're not being acted upon. And that was interesting. The second one is radical or attentive listening that Dr. Glasgow had mentioned. And this is where that the clinician, you listen and you use your intuition. You use the empathy and you bear witness to what someone is saying. I would also add that radical listening is active and respective listening. It's not interrupting the patient, not saying, well, wait a minute, let me tell you, what was the order again here? Shouldn't you be doing it this way? You're listening. And Dr. Sharon mentions references in psychiatry, listening with the third ear, which includes listening, but also being very attentive, which I'm sure a lot of you are, to a patient's body language as well, to the gestures, to seeing what's happened, what's being said with a clenched fist, for instance. That, and although these techniques, one more. And then thinking with stories, this is what I really want to will build up today, is that usually we are thinking about stories. And when we think about a story, the story, for instance, if we say the patient gives us a story, a history, if we think about it, it becomes an object. It's something out there. We're distanced from it, and we think about it that way. Thinking with story is different. As Arthur Frank, who I'll talk a little bit more about later, says, to think with the story is to experience it affecting one's own life and to find in that effect a certain truth of one's life. So thinking with story encourages, or I should say engenders, a kind of reciprocity here. So I want to put in practice some of these tools, and I'm going to use some pediatric illness narratives, and I've included some photos here. These narratives are from the camp where I worked. All of these adolescents received solid organ transplants. All were patients at Primary Children's. And they attended the annual youth transplant camp that's held annually at Camp Costopolis in nearby Immigration Canyon. It's sponsored free of charge for recipients of all solid organ transplants. So not just kidney, but also heart, liver, pancreas, and many different combinations of those. And the project, for 12 years, I offered these poetry workshops to the campers. Originally, the project was supported by the Utah Arts Council with grants from the National Endowment for the Arts and the Utah Challenge America project. When I approached the Kidney Foundation, they agreed to this, thought it was a great idea, and they said the first day you offer it, we'll have all the campers come. I was working with the adolescent campers, mostly 12 through 18. I did work with some of the younger ones, but we just kind of ended up focusing with the teens because that was actually part of the grant, was to offer poetry to marginalized teens outside of school. So I was competing, I have to say, with swimming, horseback riding, hiking, ropes course, but after their first day, I have to say that the writing their narratives of their medical experiences proved so healing, they came back the next day, the next year, and for many years after that. So as I said, I did want to talk about definition of narrative. We tell, and I've used it interchangeably here as if it's a synonymous term with story. We tell stories every day, but usually these are about routine events, and sometimes it's not anything that's even an important routine event. It can be more like an anecdote. We tell narratives, however, about something that is out of the ordinary. We're not sure why or how that something happened or what it actually means. But by creating a narrative, we can gain insight into this. And the reason I believe, which the teens confirmed, that these narrative workshops we offered were so successful because they provided a safe place where they could explore the meaning of their experiences. And at the camp, they weren't patients. They were teenagers, and they could do lots of things. And there was actually an advantage to having them have undergone different kinds of organ transplants because they could compare them then too. So that someone say, oh yeah, you're a heart. Oh, you're a liver. Yeah, you want to see my scar? Oh, it looks just like mine. And so that was an advantage, losing my scarf here. And so I want to offer this definition of narrative, which is complex, but I'll break it down because I think it's very useful, the one I found most useful when we're in a medical or health setting. Personal narrative is a way of using language or another symbolic system. And here's where I say symbolic system. Think back to blood tests. Think back to any kind of imaging. Think of visual art, performances, videos, all of that. And the idea is that it's used to imbue, to give life events a temporal or a logical order. And we tell narratives to try to understand. So we want to make sense of them in a way. And one of the easiest ways is to order something chronologically. This is how it happened. And that, in a sense, we can seem to, maybe that helps us understand it. Or a logical order. Well, this is what happened because, oh, if I look back, maybe even many years ago, oh, maybe that was the cause. So, okay, that makes sense. It demystifies it. And it also then establishes this coherence across time. And Arthur Frank is someone who talks about this, that when you receive a serious diagnosis, say you receive the diagnosis of kidney disease and you're going to have the transplant, that the past was not supposed to lead up to where it does now. So how do I make sense of what happened in the past? And I'm here in the present, and it's just seems chaotic. I can't make sense of it. I can't even imagine what the future will be. But if you step out of medicalized time into the sense of a narrative, all of that time can be understood better, and you can see ways to connect all of this. And then that becomes more healing. So I want to do a close reading here. And this is a short poem by Taylor, who was 13 when she wrote it, a kidney transplant patient. The door says McLeod, Taylor, N, period. I see them all there, the doctors and the nurses saying, she needs this, give her that. They come in and say, do this. To them, I am McLeod, Taylor, N, period. They don't know I love animals or art. They don't know about my family. To them, I am just McLeod, Taylor, N, period. So this poem, we would say, is accessible. It seems easy to understand. The speaker, in this case, we know it's the patient Taylor, although you want to be very careful when you're reading poetry not to make the assumption that the I of the poem is the same as the author. But in these cases, we do know that. And Taylor wants us to know that she's more than a patient, more than the name on her medical file. Her voice is assertive here, maybe even has an edge of defiance there. But I think if we start using close reading, that the meaning of this poem expands. So if we look at the first image in the poem, which is the door, what it begins with, and if we look at the space that the poem takes place. So a door, it begins with a door, and we can presume that it's open since the patient can see others, them, the doctors and nurses. And they inhabit a different space there, not shared with the speaker. So although a door often indicates a kind of an opening or a welcoming, here we see the words both them and there imply a separation. The second line is notable because it's the only one in the poem that starts with I, the personal pronoun. And an I, personal pronoun, has agency. I can do something. I see. And so this patient does have a sense of herself. But then we have the next three lines, and we have the italicized words that she's being told what to do. And here, that agency has transferred over to others, to the doctors and nurses. And they're giving her imperatives or commands. Do this, don't do that. And then in the last four lines, we have repetition, which you always want to say, I wonder why something's being repeated. And it often adds a kind of emphasis. And here we have to them, and then they don't know. And what we have here then is the emphasis on the disconnect between the speaker's sense of I and her clinician's interpretation. So the entire poem is essentially an argument about what happens to a teenager's identity when she's transformed from a person to a patient. And as you all know, defining oneself and the sense of personal identity is a key developmental task for adolescents, which illness and disease radically complicates. But I think through close reading, we actually are then urged to look at it and use attentive listening, which will tell us even more. Here's where we try and read and hear her voice with empathy and concern, and thus we wonder, I'm hoping you do, that why does Taylor invert her name 3 times in 9 lines? That's quite a bit. No doubt in schools, she is accustomed to being placed in alphabetical order by her surname. And as a patient, wouldn't she be used to seeing her name printed that way on medical records, maybe even the wristband that she wears? I'd suggest that Taylor is telling us that surgery literally turns the body and the way we know ourselves inside out. Illness doesn't just change the direction of our lives. It turns them upside down. It inverts them. So by writing this poem, Taylor is literally reversing herself. By writing a narrative as a poem, and she reclaims her voice and her sense of agency. She is the author. She has the final word here. So what we can learn from some of the poem here is that we can receive consolation and hope from authors who have the courage to articulate the situation of their lives in all honesty and directness. Their courage to to enter so deeply into human suffering and to become present to their own pain gives them the power to speak healing words. With her narrative, Taylor is connecting those who distance themselves, her caregivers, her clinicians, the doctors and the nurses, and showing us how to care. DeSalvo, Louise DeSalvo was a language literature professor and was really a Virginia Woolf scholar, but focused an awful lot on illness and how that writing about that can be healing. And she references in her book the root meaning of care, which comes from a Gothic expression meaning to grieve, to experience, to cry out with. So, or to lament. And this is what Taylor is doing with her poem. We show we have cared about someone by letting ourselves engage in the act of lamenting their loss, joining in their grief. By engaging in lament, we care for ourselves. For not to express grief is to put ourselves at risk for isolation and illness. And again, that kind of reciprocity. So to Taylor, to be caring is to listen to her, but it is also just to be with her, not to do something, not to be telling her, but just to being with her. So this next poem is by Amber, who was 16 at the time of the transplant, and we'll read it through. I survived so many things I don't think I could survive anything else. I survived biopsies, at least 20 of them, if I remember right. Every time they rush me down here, they want to biopsy me. It's like, please, no more biopsies. So to give you a little bit of background here, when she says they rush me down here, Amber continues to live up in the Logan area. And so she was brought down to primary all the time. So she was talking about rushing down. So if we look closely at the kind of a close reading, you'll notice that in the first 4 lines, some variation of the word survive appears 3 times. I survived so many things. That's a general statement. It is a declaration of survival. You can sense Amber's pride and ownership of that fact. I have survived. But then she says, I don't think I could survive anything else. Doubt is starting to kind of creep in there and doubts her ability to continue surviving, to continue living into the future. I survived biopsies. So first it was I survived many things, then it was anything else, but that all is in reference to biopsies. She says 20 biopsies. And even if she'd had the transplant as an infant, which she didn't, she was, I think, around 7 years old, but even if she had 20 biopsies in 16 years is quite a few, I think. And so now I want to look at the 6th line in parentheses, if I can remember right. And again, there's some doubt. I don't know, maybe I'm not remembering right. But this time she puts them in parentheses. And that means that that information is not as important. That's the purpose of putting parentheses in. It's subordinate information. But parentheses also have meaning from a rhetorical standpoint. They are an interruption. And this line shows us that there's an interruption in this poem. So whereas the first 4 lines, we have the word survive 3 times. If we look after that time, or then from the rest of the poem, we have biopsy 3 times. And so she's telling us she can't survive another one. One more biopsy will literally cross out the possibility of her survival. So if you even think about it, 3 times she mentions survival, 3 times biopsy. If biopsy appeared one more time, that would actually cross out the significance of survival, if we want to think about it that way. But I think what we really want to hear when we're listening um, with radical listening, attentive, respectful listening, is that she's saying biopsy is not a benign procedure. Yes, it is less complicated than transplant surgery. And yes, it's something that needs to be routinely done to ensure that she's not having any kind of kidney rejection. But it still is not benign. And it's painful on another level, and I'd say an existential level. Because when we look at the line, they want to biopsy me. She's not saying they want to biopsy my kidney. They're not saying she wants to biopsy a part of my body or my body. She's saying me. So, like many patients, Amber is her body. And that's what we can really hear here. Let's see. Oops. What? No, that was the other way. Okay. So, what we can learn about empathy, I think, from Amber is from Arthur Frank. And he says, observing what stories say about the body is a familiar sort of listening. Describing stories as told through the body requires another level of attention. And I wanted to note, I said I was going to talk about Arthur Frank, that this is the first book he wrote, The Wounded Storyteller, and it's really a classic in this sense. He is a professor emeritus of sociology at Columbia and is also in the medical school. And as a young man, he was diagnosed with and treated for testicular cancer, and then later for some serious heart conditions. He was able to reflect upon his experience with both the perspective of a patient and a medical sociologist. And so it's a very interesting and a very insightful book, I think, so that when he's talking about this, he knows what he's saying about how something is really said through the body. One of our most difficult duties as human beings is to listen to the voices of those who suffer. They are describing conditions of embodiment that most of us would rather forget. It should be : our own vulnerability. Yet listening is also a fundamental moral act. In listening for the other, we listen for ourselves. Then we can empathize with others and treat them well. This then is the foundation of living an ethical life. And so this will be the last illness narrative we'll look at. I can hear my heart beating as I enter the room, not knowing if I will ever wake up or live, as they move me to the OR table. Then they strap me down. They put a mask on me. I smell the gas enter the mask. I taste the plastic of the mask. I begin to spasm. When I wake up, I see my dad, knowing I lived. I'm real glad to see him. So Marcus organizes his surgical experience in a chronological order. He's using narrative to find a logic in what he experienced before, during, and after his transplant. I think the final 4 lines are particularly powerful due to Marcus's honesty. If anything, he underplays what many teens would overly dramatize: realization, confrontation with his own mortality. Using radical listening, we can hear how the narrative enabled Marcus to console himself, to gather strength and courage. He witnesses his own experience with mortality from a safe distance of time and space at the camp. With writing, he transforms a threatening experience into a creative activity. But the impact of Marcus's narratives on his fellow campers was phenomenal. And so I wanted to say, I don't know if you noticed in the first photo with the teens, and some of them were all holding some papers up to the face. All the girls were sitting there that way. So what we did is we would all read some poems together. I would give them a prompt, and I'd hand out yellow pads, and they would write on the pads. At the end of the workshop, I would collect the pads. I would take them home and transcribe what they wrote using re-narration, which is a qualitative research method where you shape what someone says is into a narrative. And I did it for poems because that's what we were looking and reading at. And I had told them that's what they could write, because in poetry, you don't have to worry about your punctuation. You just can, it frees them up and gives them a different kind of writing. So I would take those pads, transcribe it, type it all up, and then have handouts the next day. And we would all look at those, and then they would take turns reading their poem aloud. Marcus did not want to read his poem. Everyone had already seen it and read through it probably on the handout. And so when he said, no, he didn't want to read it, a few guys next to him were, come on, Marcus, you can read this. And then a few more and some girls, oh, come on, Marcus. And next thing, it was not just a few people, it was the entire room full of teenagers who started chanting, Marcus, 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 and clapping for him. And I said, I can read it for you. And then JD, who was his same age and also had a kidney transplant, did not know each other. Marcus was from Texas, and JD was from Utah Valley. But he stood up with him because he knew what it meant. And there they are. You can see Marcus has some additional conditions that stunted his growth. So what we did is we were bearing witness with his poem, but more so, we were learning how to think with it. We completed, through listening, the meaning of his poem and echoed it back to him so he could fully understand the significance of what he had written. And DeSalvo has said, there is a moment then when there is no I, no you, only we, one of connection and communion, of conspiracy, a breathing together. So the teens were thinking with Marcus's narrative. They were allowing his story to affect each of their lives and to find a certain wisdom in it. Marcus was the only one of the 19 teens that first day to write about his medical experience. After that, everyone else eventually wrote in detail about surgeries, about different medical conditions, their fears, and their mortality. That became a topic that everybody would discuss. So now we're wrapping up. I want to bring it back to pediatrics, and that there's obviously benefit in this. However, it was interesting to me, I've mentioned it to a few people beforehand because I think this is a really rich area for all of you to explore here, is to incorporate narrative. There was a study I found that was published last year, and it was drawing on experiences in a hospital in China, looking specifically at pediatric nurse specialists. But in that article, they did make a general statement that narrative competence is crucial for ensuring that patients receive optimal, humanistic, and high-quality nursing care, represents an innovative approach to enhancing patients' health outcomes. And then they noted that pediatric nurses, and I think this challenge here is for all clinicians who are working with pediatric patients, the challenge of children's limited ability to express themselves and parents' high expectations for the outcomes. But they do say that advanced narrative skills will help clinicians develop personalized and holistic care strategies. And the recommendation, Educational institutions should integrate narrative medicine into nursing curriculums. I also found that there were several stories referencing pediatric residency programs, and I know that there have been some narrative workshops offered for groups here. And this particular one said narrative medicine is a feasible, replicable, and accepted teaching modality for pediatric residents to foster empathy, process emotions, and participate in self-reflection. There have been several that were specifically for pediatric residents working in critical care areas. Narrative medicine helps residents value their own emotional responses to their clinical work, underscoring the real and human responses trainees have to critically ill children. And I was really drawn by one comment in a qualitative interview included where a resident said, "We were finally asked in narrative medicine about how we were genuinely doing, not just as physicians, but also as human beings." So we're just couple final thoughts, and actually these are final quotes from other people, but I want to leave you with these because I think they're very powerful. And this is a call for physicians, clinicians, and trainees. It comes from Dr. Rita Sharon. As witnesses of other pain, we expose ourselves to suffering, and so we suffer ourselves. To be equal to this task is our humble hope. And one of the ways she would say then, is through narrative medicine. But for all of us as human beings, DeSalvo says, illness often confers a wisdom about how to make ordinary life deeply and transcendently meaningful. And this is through reading, listening attentively, and thinking with stories. The point is, as Frank said, is what a listener becomes in the course of listening to the story. So thank you very much.
I've been thinking about the interpreting and retelling the stories. You know, at this hospital, our nurses hand off to each other at when they change shifts at the bedside, right in front of the patient, they're telling the story to each other. When we have family-centered rounds, we retell the story with the patient there and they can correct us if we're wrong. When I'm admitting a patient in the middle of the night, it might be the 6th time the parent has told the story. So I always give them the option of, would you like to tell me the story, or should I tell you what I've heard and you correct me, you know? And sometimes it's surprising they're not tired of telling the story. They want to be heard again that maybe they haven't heard it yet. So, and I can't believe they're doing this. This is great. But so there's so many different ways of retelling and listening. And I think my favorite part of all the poems is when Amber said, it's like please. And they just, and I know it's a poem and she chose all those words. To put like in there a couple of times also brings me into really the teen's voice and really hearing her. And I thought that was lovely. And what makes me want to put more kind of direct quotes in my doctor notes and more vivid descriptions in the general part of the exam, because everything ended up being checkboxes. But I don't know, it's really great. I want to see what any other comments you have, another question.
Yes. Hi, my name is Dr. Ward. I'm an old doctor. I've been a doctor for 55 years. One of the best grandruns I ever had in my life is I really enjoyed it. Wonderful grandruns. Thank you very much. My question is, look at the audience, most of us are old people. How do you teach the younger people importance of this? Because today if you give a lecture, you won't know. Is it testable? That's the first question I ask you. Second question, I don't want to hear stories. Tell me a fact. How do you teach young people today to follow what you're saying?
Well, actually, yes, I would counter that working with medical students, and I also worked with, I taught a class on main campus for undergraduates who are going to pursue a career in healthcare, some kind of healthcare. And all of those students were very interested in listening. And so to them, I think they're looking at health and medical practice from a broader perspective. And I know there's several people in the audience who are residents too. And I know them and have worked with them, and they are opening up. And I think also that they are aware of and maybe experiencing this kind of reciprocity that I said. And it's not the best, the best word necessarily, but where if you as a student are given, as a trainee, are given opportunities to write about your experiences, how something has affected you emotionally, existentially, then that gives you a different perception of the patient. And so you often invite that kind of response then too. And as Dr. had said, that you don't mind, that you realize that you were listening really well and realize that parents don't mind telling a story 6 times, because each time they are having someone listen to them, it comes back to, the story comes back to them, and they can start hearing it in a different way. And also, it's probably really interesting for parents to listen to say, oh, and that doctor or that nurse repeated this detail, which I wasn't sure really why it was important, but now I see it in the whole context. So I think there's an openness now, just with the change in times, to narrative.
Thank you so much. That was so amazing and inspiring. I would be really curious to hear more about the re-narration process with the camp. Like, I was curious, do the kids write on their yellow pads? They're kind of writing stream of consciousness, or did you teach them poetry techniques beforehand, or like what was that like in turning it into poems? Because these poems, like the last one, made me cry. It was just so beautiful, and yeah, I'm just curious to hear more about your process.
I couldn't really teach it. So I have to say, the first day that you could see Marcus, if you didn't notice, Marcus and JD were in front of a whiteboard. And I brought a whiteboard and I had a dictionary there. And I was kind of making some references to these. And so after the first day, they're all, ditch the dictionary in the whiteboard. We don't want to see that. So a lot of it was just kind of, which fit with poetry as an oral tradition, is that I would read them poems, and sometimes I would show them, or put something on some poster paper. Like there was one day I had some lines from Mary Oliver, and then they could write their own responses. So I had to present it in a way that was meaningful to them. And I did tell them, that you don't have to worry about the punctuation. You don't have to worry spelling. So I should say that the re-narration, that I didn't edit anything. Those are all their words. I would correct a misspelling, and they didn't use a lot of punctuation, but they wrote it. They got the idea, and they started writing separate lines. Every once in a while, we'd take something down. Amber, there was an interesting example of a poem where Amber was just talking about how mad she was. And she just started this, it was stream of consciousness, go on and on and on. And I just want to hit someone, and I just want to do this, and it was like, whoa, Amber, let's just, let's look at this again. So we take one line, and she just, from that, we came up with something that was a poem with much fewer lines, but it had so much impact. And she stops and she looks at it and she's all, wow. And I think the wow was was always their response. And I still get this when I'm working at Huntsman all the time with patients, that if they, and I should say, because with the patients at Huntsman, a lot, like working with them in infusion, and I type out what they say on the computer because they don't feel well. And there were some kids that had some difficulty with dexterity. There were some that had, I wouldn't say some maybe slight cognitive deficits. These were not kids, they didn't do well in school because they'd missed so much school too. And so we did have some people available to scribe for them, some counselors and so forth. But a lot of times they just go, JD one time said, nope, I'm doing it by myself now. I got it, But it was because this was also before texting and cell phones. And this was before some of the social media. So this was a chance for them to see their voice in text, and it looks different. I mean, even for adults now up at Huntsman. that I can give them something they've written and they'll look at it and go, wow, that really sounds like me. And it's like, it is you. It is your voice. But to see it there, that is a kind of a listening then too. Is that answering some of that? Yeah. Yes.
Yes, that was really very inspirational, thank you. I have two observations, comments. One is you alluded to the fact that younger children, it's a little more challenging, right? So I remember a lecture at a child neurology meeting given by one of our grandparents of child neurology, an amazing talk. And Paul Rossman, he died this year. And he literally had every single patient he saw draw something for him. And then he interpreted these drawings much in the way you did. So I would say that's another, I mean, it's not a narrative in a written sense, but it's a narrative in a pictorial sense.
It's a visual narrative.
Yeah.
No, I'd say it is. I do have to say, I worked at Camp Hobie. That's for children who have cancer and their siblings. And I did work with a lot of the young children there too. And for some reason, we could write more. They had a little bit better grasp at that point. But and I have worked in the schools as a writer in the schools with first, second, third graders. I'm working with some second graders right now. And you can, the poems become like one sentence, you know, there's not a lot there, but still they do feel a certain power and fun in that. And they're also at that age, what I've noticed is that they tend sometimes to copy what someone else is saying, you know, what they're writing, because it's like, oh, well, I'm just, you know, if this person is pretty smart in class and they're doing this, I'm going to do the same thing. So I do see a lot of that, but yeah, but thank you. I appreciate, and yes, the imagery and the pictures.
Second thought, and I'm sure everyone thinks about this, but the EMR, the electronic medical record, is a tremendous barrier to this. And I would say one of the frustrations I have as a consultant is I'll go to the chart and read, you know, not to pick on the NICU, but look at the NICU note, and I have absolutely no idea of what this person is. I just have a set of problems.
Yeah.
And we need to include, in my opinion, the narrative, at least at the beginning of the note or at the end or somewhere in there,
Yeah.
to have some concept of this human being as opposed to a collection of medical problems.
Right.
And I wonder whether people in this field have looked at that issue and have some suggestions on how to address that.
There are actually some studies that are being done on this, and in many different ways. The VA has something where you can add on to the patient chart, and it's kind of just a description, a kind of subjective description. I just recently read about they're doing some studies where they have nurses have a narrative diary, and it might be a digital diary, and they can keep that at the patient's bedside. And so then that's passed on to others. So there are some different innovations being done that way. There was one other one I was thinking of, but yeah. And so I would strongly suggest, you know, trying something like that here. Yeah. Yes.
Neonatal representative. Hi, Fran.
You didn't know he was here.
Actually, I was thinking this very same thing. And because there's another aspect to this as well, is in the age of transparency, patients now all have access to their medical records immediately. So I have patients that actually know things before I know them in the mornings when I come through. But they're also reading our notes. And these notes are a perspective of our view of that patient. In the NICU, it's the patient and their family. And one of the things I'm finding is we do not do a good job currently in translating our thought processes or maybe some of the communication distresses that the family has, or even positive things about the family. So like when I put a little narrative about, you know, when I update a family and I put that in the note, I try to put in their parents asked very excellent questions, just something that says to the family, wow, you guys are doing good. But our nurse practitioners are the ones, and PAs are primarily doing these notes. And I don't think we are teaching them to put in our medical decision-making in some of the things you would think of as narrative or important things in the sake of brevity. And in fact, I get hammered on by some of my colleagues for being too verbose for that. So I think that's a very good point, Fran, and I guess one question is how can we help? We have now mid-level providers that are so much more integrated sometimes with our families than we often are. Are we doing things to help them to expand in this area? Like the nurse practitioner school, the programs that we have and the teaching we're doing there.
Well, I've actually worked some with some PAs a number of years ago and introducing narrative. But let me give you two quick examples of something that can be done and that is being done here. Over in the surgical intensive care unit, there was a physician there just a couple years ago and had a project, and she didn't come up with it. It was pioneered someplace else. I want to say maybe San Diego, called 3 Wishes. And they would ask the patient, what are 3 wishes you have? And then they would write those and put them by the bed. And it could be something like, I wish I had a vanilla milkshake. I wish I could do something. And so they were very tangible items, and they put them up there, actionable items, a lot of them. And then people coming in could say, oh, I see you said something. Tell me about, why do you like vanilla milkshakes? Why not, pistachio chocolate chip? So something that opens up a conversation. And there's actually a medical student right now who is working with a project. She is putting that together at IMC. And it's something very similar where that they're getting some descriptions of the patient. And I think the patient gives some of those. And again, they put them on paper above the bed. And it's just to encourage anybody, any medical professional who comes in, to ask some questions that are not medically related.
I think that's incredible because that connection is, I tend to, when I first meet a family, is I ask them, oh, his name's Noah, where did you get the name from? And a lot of times it's like, well, we Googled it. But it's amazing to see a family that's up here all of a sudden open up and you see this stress level go down. And then we start to connect on, oh, you named him, there was a climber, and oh, you like climbing, and you can take that and expand. And then there's just a little connection because they see you as interested in their patient. I'm sorry, I'm rambling on, but
No,
that's
but
just
exactly.
just one little question that you can do that often will open up those doors. So that's fabulous.
A really easy technique.
Thanks
Yeah,
again for
I'm
teaching
probably
us
one of
what-
the non, the
Could
two
you
of us,
hold
we
on
are
just
both,
a second?
oh, sorry.
I just have to adjourn it for people to leave if they need to leave, but the claim credit code is 52531. And thanks again for teaching us. But yeah, any other questions, you can continue, it's fine.
I'm a chaplain, this is my colleague Mia, my name's Nancy, this is Mia, and we're both chaplains. And so the focus of chaplaincy is, our tagline is meaning, purpose, and connection. That is our role. It's not religiosity. It's about meaning, purpose, and connection. And so when I'm thinking about the notes, most chaplain notes, at least I hope here, have some of that. We often will use quotes of a patient, and you'll hear pieces of a patient or a patient's family story within the note of the chaplain. And we also have a little flow sheet that the rest of us have with our checklists, et cetera. But that is one thing I know that we try to emphasize here, that there is some narrative that you know something about the patient, whether they love horses or they love vanilla milkshakes or their family lives far away and they miss them or whatever the case may be. So just on the charting, you might also look at a chaplain's note. You might at least, I know it's indirect and it's third person, you don't get to hear it directly, but you might learn that much more about the patient in the chaplain note, so.
Yes, thank you. I've worked with some chaplains, and
Yeah.
it's a wonderful service. And yeah, I think that sometimes we have a narrow vision of perspective on what a chaplain can do, but it's making that human connection, which then helps on an existential level of healing too.
I have a daughter that has a cleft lip and palate adopted from China. And she's gone through years of 20-something surgeries, endless surgeries. And finally it came out just last year, she's 15, that she's felt broken her whole life. Whenever a physician is looking at her, they're not they're just saying we need to fix this, next is the nose, next is the soft palate, the hard palate, the ears. And she's like, Mom, my whole life I've felt broken. Doctors just look at me and say what they're going to fix next.
Right.
And so Dr. Dana Johns, we were in her office, she's a plastic surgeon, like a month ago. And again, the same thing was happening. And I said to Dr. Johns, I said, it's recently come out that Jill feels broken. And Dr. Johns took a minute and she paused and she said, she actually got a little teary-eyed and she said, Jill, I'm so sorry that you feel broken. You are not broken. And just to hear that from a physician was so beautiful.
Yeah. Oh, that's a wonderful story. Thank you. Yeah.
Can I tell a very quick story? I'm a hematologist. At sickle cell patients, they were transferred 18 years from Children's Adult Hospital. So I transferred a patient. 2 years later, she was dead. So I went for the funeral, and she wrote a poem saying that at 18, Dr. Wall will transfer me, and I will die somewhere else. So I still can't get over what she wrote.
Yeah. Thank you. Thank you all very much.